بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أنا الدكتور حاتم أمين خطاب، استشاري أول طب وجراحة العين بكلية طب الزقازيق. نفس الستايل أو السيستم اللي ماشيين عليه اللي هو بنعمل كلينيكال كيسز بصورة واقعية عشان نفهم المواضيع بتاعتنا. أول حالة معانا النهاردة عيان ميل عنده 25 سنة من الجزائر. الشاكوى بتاعته اللي جه بيها للطبيب progressive bilateral visual loss over 1 year، زائد كان عنده episodes من eye redness, intolerance to an ordinary amount of light or photophobia. He reported a history of recurrent bilateral panuveitis treated with both systemic and topical steroids, plus migratory arthralgia, plus recurrent oral ulcers. Past medical history was unremarkable. Also, family history was unremarkable. On ophthalmic examination, best corrected visual acuity was 20 by 100 in the right eye and counting finger in the left eye. On slit lamp examination, there was mild ciliary injection, cells and the flare in the right eye, mild ciliary injection and anterior chamber ciliary reaction, and immobile hypopion with pupil fibrin exudates in the left eye. On fundus examination, there was bilateral vitritis, which was more marked in the left eye, with multiple inferior vitreal exudates. Ongoing fundus fluorescein angiography, diffuse fern-like vasculitis was detected bilaterally, with significant optic disc and macular leakage. The lab investigations done in this case: complete blood count, erythrocytic sedimentation rate, liver function tests, kidney function tests, tuberculin test, VDRL test, troponin pallidum hemagglutination test. The tests were negative or within normal limits. This is the time for questions and answers. The first one, what is your diagnosis? Of course, the diagnosis is Behçet's disease. What is the clue or the evidence for this diagnosis? First, bilateral panuveitis characterized by fern-like pattern retinal vasculitis with unilateral hypopion, plus the patient characters. He is a young male coming from the Mediterranean area, plus history of recurrent oral ulcers and arthralgia. Because of reduced visual acuity, the turbidity of the media in the anterior chamber in the form of self-flare hypopion, plus the vitritis and the posterior segment affection account for the reduced visual acuity. Also, in these cases of uveitis, there is spasm of the ciliary and constrictor muscle. This may produce some sort of myopia. The treatment prescribed for this patient included prednisolone tablets, azathioprine, topical prednisolone acetate, topical cyclobentalate. The result there was an improvement in both anterior and posterior segment inflammation with resolution of both hypopion and vitritis and a complete regression of vasculitis in 3 weeks. The second case, a 30 years old male complained of right eye headache and eye pain, ocular redness, intolerance to an ordinary amount of light or photophobia, plus visual loss over 3 days, following a history of eye trauma from a wire while working near a construction site. On visual acuity assessment, visual acuity in the right eye was hand motion, good projection, and 6 by 6 in the left eye. On slit lamp assessment of the anterior segment of the eye, this was the appearance of the right eye, mucopurulent discharge, ciliary injection, conjunctival edema or chemosis, corneal ulceration with epithelial defect, anterior chamber plus 4 cells, hypopion with fibrinous pupillary exudates. On doing B-scan ultrasonography, it revealed vitreal exudates and membranes. Left eye examination was unremarkable. Regarding the questions related to this case, what is the diagnosis? The diagnosis, of course, is traumatic endophthalmitis. Endophthalmitis means intraocular inflammation, principally involving the vitreous body. The evidence for this: history of eye trauma, typical symptoms, vitreal exudates, hypopion, flare, cells, and ciliary injection. The investigations performed in this case, we did a vitreous tab to obtain a material for the microbiological lab for culture and sensitivity, and it detected the presence of Staphylococcus epidermidis in the tab. Plus the vitreal exudates and membranes by ultrasonography. احنا بنقول دايما اللي بيشخص هو اللي بيعالج، ما عندناش واحد بيشخص واحد بيعالج. ايه التصرف اللي هنعمله في حاله زي كده؟ This is an emergency. اول حاجه السيرجيكال ادميشن او hospitalization. بعد عملنا التاب بتاعنا على طول بندي انترا فيتريال انجكشن لسيفتازيدين للفانكومايسين الديكساميثازون، وبندي كمان توبيكال فانكومايسين اميكاسين اتروبين سلفيت as well as prednisolone acetate. Systemically بندي systemic vancomycin and ceftazidime. The differential diagnosis for this case is this is the only possibility. This is a list of possible infections that could produce hypopion uveitis. And this is a differential diagnosis of non-infective hypopion uveitis. Not all hypopion uveitis is infective. It may be non-infective as well. We have certain rules. Pigmented hypopion, like this case, is usually related to infective processes associated with intraocular tuberculosis, Listeria monocytogenes endophthalmitis, or malignant melanoma. Hemorrhagic hypopion may be the presenting features of lymphoma or leukemia. The third case today, a 27 years old male from Norway He came complaining of recurrent attacks of ocular pain, photophobia, and red eye. On ophthalmic examination, we detected an anterior chamber fibrin, a hypopyon with mild ciliary injection in the right eye. The left eye anterior segment examination was unremarkable. These are both the right and left eyes together. Visual acuity assessment was 6 by 60 in the right eye and 6 by 6 in the left eye. The intraocular pressure was 35 mm mercury in the right eye and 16 mm mercury in the left eye. This is the fundus examination of both eyes. It was unremarkable, apart from haziness of the view in the right eye. Regarding the past medical history of this case, the patient had a long-standing back pain and stiffness that were usually worse in the morning and improved with activity or exercise. Regarding the investigations done in this case, HeLa B27 was positive. X-ray on the lumbar spine revealed what's called the Pampu spine. This is the X-ray on the sacroiliac joint. First, the question, what is the diagnosis? This is a case of ankylosing spondylitis. Can affect the eyes, the shoulders, the gut, sacroiliac joints, the skin, the knees, and the heels. Many symptoms should be searched for in this case. All these systems may be affected, and the symptomatology we should be familiar with. This is a modified New York criteria for ankylosing spondylitis. The cause of reduced visual acuity is the turbidity of the anterior chamber by cells, by flare, by mild hypopyon, spasm of the ciliary and constrictor muscle. These factors reduce the visual acuity. The hiddenness of the right fundus photo is due to turbidity of the anterior segment cells, and the flare make the fundus view hazy to some extent. Elevated intraocular pressure is due to the turbidity of the anterior chamber. It reduces the facility of aqueous outflow. We can name it a secondary open angle glaucoma. There is a list of some of the possible complications that could be encountered in such cases. We may get posterior synechia with a partial or ring. We may get complicated cataract. We may get band-shaped keratopathy, plus the skeletal deformities that may follow long-term untreated cases. Here's an example of other cases with ankylosing spondylitis and uveitis. In this case, we can detect definite cellular injection and necrotic precipitates. This case that we can find the hypopyon in patients with ankylosing spondylitis and anterior uveitis. The hypopyon typically is fixated, and it takes a long time for reformulation at the headmost, unlike the hypopyon observed in Behçet's disease. Case of anterior uveitis with hypopyon due to ankylosing spondylitis before and after treatment. Typically, keratotic precipitates in ankylosing spondylitis are dust-like keratotic precipitates. An example of inflammatory cells and the flare in the anterior chamber in case of ankylosing spondylitis with acute anterior uveitis. AAU means acute anterior uveitis. A case of hypopyon and cellular injection in ankylosing spondylitis. The home message for this presentation: uveitis is not just an ocular problem. In many cases, it may be a part of a serious systemic and sometimes fatal systemic disorder. For communication, this is my WhatsApp number. This is one of the YouTube channels. This is the Facebook page for students. Your feedback is highly appreciated, and I hope you enjoyed it. Thank you.